Hi there, everyone. For this assignment, I chose to talk about ARFID, or Avoidant Restrictive Food Intake Disorder. I chose this topic because it is something that I have continued to see more of on social media, and I have also had people in my social life or my personal life ask me about it, so I just wanted to take this opportunity and learn a little bit more. Just a little brief overview of ARFID before I jump into my articles. Avoidant Restrictive Food Intake Disorder, or ARFID, is a newer eating disorder. I think it was added to the DSM-5 in 2013, but symptoms often include a disinterest in food or disinterest in eating, avoidance of food intake, and a fear of consequences associated with food intake. So the first article I want to talk about is titled of ARFID Strategies for Dietary Management in Children. The purpose of this study was to review the current literature surrounding ARFID, including the dietary strategies to manage ARFID. So that's just kind of what I'll be presenting on for this article. So when we're working with pediatric individuals with ARFID, the dietitian should not initially attempt to make changes to the eating behaviors or the foods consumed. Even if the safe foods being consumed are considered to be unhealthy, removing or replacing the foods too quickly would cause the patient to choose hunger over adapting to the change. So we want to use food chaining as part of an intervention. That's one of the first interventions discussed because these changes can be made gradually over time. It's also not advisable to hide or to disguise any of these foods as something else because individuals with ARFID only accept a certain form, texture, color, sometimes even prepared by the same person. So that would not be advisable. The role of the dietitian is to monitor the weight status and weight change, the nutritional status, and to analyze the foods that should be introduced by food chaining first, recalling the similarity to the specific individual's safe foods in an effort to avoid malnutrition. The next management strategy discussed was called the Feeling and Body Investigators. They abbreviated it to FBI, with feelings of the child being perceived as something interesting rather than something to be afraid of. So they experienced unpleasant sensations, and the child was taught acceptance through play. So increasing this awareness can help reduce the anxiety and increase acceptance. So the avenue, I thought this was interesting, the avenue that the article took was playing FBI agent with sensory superpowers to explore these sensations and, again, increase acceptance. The next intervention was the family-based treatment ARFID model. So it's a little bit different than the normal family-based treatment model, but changes in the intervention reflect focusing on eating behaviors rather than specifically focusing on the restoration of a normal weight. Phase 2 and Phase 3 would also be different, as Phase 2 would occur when the child is consistent in trying new foods, and Phase 3 often doesn't occur. In individuals with food anxiety and low appetite, the intervention of the family-based treatment ARFID model may require more adaptations and more specific interventions to target the goals surrounding dietary diversification. The article did say that the most effective intervention is cognitive behavioral therapy also. So if this article taught me anything, it's that the treatment of ARFID requires both an emphasis on nutritional and behavioral interventions, and that the dietitian can play a key role in understanding the specific individual, their specific nutritional preferences, along with how the appropriate intervention can facilitate desirable results. I think that dietitians are uniquely able to provide this kind of support and intervention for this population, and it would be an interesting area to continue researching. So the second article I chose was titled Avoidant Restrictive Food Intake Disorder and Severe Food Selectivity in Children and Young People with Autism. So autism spectrum disorder is a neurodevelopmental condition with behaviors and needs that can affect sensory preferences, rules surrounding mealtimes, and a limited food library. These behaviors and needs can impair the amount of food consumed and place individuals at an increased risk for feeding difficulties, along with oftentimes meeting the diagnostic criteria for ARFID. So it's important to note the distinction of traits of autism may exacerbate feeding difficulties, not often contributing to the onset. There is also limited research surrounding autism and ARFID. So this article just provides a summary of the research out there. So in this population, sensory difficulties are common, being the most cited throughout literature. ARFID in children with autism can lead to poor health outcomes, with a restricted diet contributing to weight loss and an inability to meet expected growth and developmental outcomes. Although individuals may be overweight as a result of monotonous consumption of foods that are high in fat, sugar, salt, often these processed foods are safe foods in this population. Poor dietary diversification can also lead to, increased deficiencies, including anemia. Oral supplements, while helpful, are not often accepted in this population due to the sensory preferences. Another interesting finding reflected the psychosocial consequences of individuals with ARFID, as they often prefer to eat alone and avoid social situations. This can lead to social isolation. Challenges may reflect that fear of eating a new food, and also eating a new food in front of someone at meal times. This is similar to those individuals with autism, as they are already at an increased risk for social isolation along with those specific food rules. So the primary objective for intervention in this population is to identify the etiology of the eating difficulty and adjusting the intervention to increase food intake based on the specific individual. Family-centered interventions to improve mealtime behaviors, increase consumption of food, and to improve food avoidance have been noted, with outcomes improving dietary diversification, food acceptance, quality of life, and also decreasing parental stress. So knowing that ARFID is a common comorbid condition in those with autism will allow us to keep an eye out for those symptoms and behaviors, as these sensory sensitivities surrounding taste, smell, color, texture, things like that are similar in both conditions. Throughout this review, it's kind of evident that there's quite a bit of clinical overlap in the nutritional habits in those with autism and those with ARFID, including food refusal, nutritional deficiency, inadequate development, impaired psychosocial functioning. So adjusting the intervention to be specific for the individual, along with combating inadequate growth, deficiency, adjusting for sensory preferences, things like that, will be important to improve health outcomes. The third article that I chose is titled "Avoidant Restrictive Food Intake Disorder Prevalence is High in Children with Gastroparesis and Functional Dyspepsia." So gastroparesis is characterized by delayed gastric emptying, with symptoms including feelings of fullness, bloating, nausea, and abdominal discomfort. In children and adults with gastroparesis or functional dyspepsia, eating may exacerbate these symptoms. Patients often reduce their food intake in an effort to manage their symptoms, along with sometimes self-imposing these dietary restrictions. So this study focused on patients aged 10 through 17 with gastroparesis or functional dyspepsia compared to healthy children. They were matched based on age and gender. These individuals completed the 9-item ARFID screen, or NIAS, and the PICA ARFID Rumination Disorder Interview ARFID questionnaire. The NIAS survey is something that I'll talk a little bit more about later. But anyway, the study found that ARFID is prevalent in children with gastroparesis and functional dyspepsia, with a positive screening persisting after 2 months. So another interesting conclusion was the validation almost of the use of the 9-item ARFID screen and the PICA ARFID Rumination Disorder Interview ARFID questionnaire. That's a mouthful. But anyway, the 9-item ARFID screen is something that I saw continuously throughout literature, and I thought it was interesting that this article almost validated the use, along with noting that it could be extremely beneficial to use in a clinical setting because there's not too many questions. Fear subscale scores were higher in patients with gastroparesis and functional dyspepsia, and there was no difference in the lack of interest in sensory subscales. So this is interesting because the food avoidance behaviors could also be overlearned from exclusion diets that we often see in prescribed to patients with gastroparesis. The importance in determining the difference between self-induced restriction due to the GI disorder versus ARFID, as ARFID diagnosis requires a feeding disturbance beyond what may be expected of a GI disorder. So noting that distinction is important as well. So overall conclusion for this article, recognizing the prevalence and symptoms of ARFID in this population is necessary to encourage the appropriate dietary and behavioral intervention that also accounts for recommendations for gastroparesis. The treatments for both gastroparesis and ARFID differ greatly, with restrictive diets being common interventions for gastroparesis, while in ARFID we try and improve that dietary diversification. Knowing that ARFID is a common comorbid condition and those with GI disorders will, again, allow us to identify those symptoms as they arise, including that fear, the avoidance of food due to the fear of consequences associated with intake. So I would, use the conclusions from this article along with some of the conclusions from other articles that I summarized to just create an individualized approach for the intervention, as there's not quite enough literature to support one intervention in this specific population. So yeah, those were the articles I summarized. Thank you for listening. Please let me know if you have any questions.